There's no syndrome? They told them already asked them for documents, so they're interested. You may be to the next slide. Tressa, I think your search question is. We hit the bypass.
Have a seat.
Okay then.
You will if you don't.
So I changed this because for the house staff, when I do this, for the medicine house staff, it's what they want, they need to know for their boards. I'm Leslie Staudt, I'm Rheumatology. I've been here since '09, and I'm originally from San Antonio, native. My father was born here, my grandmother was born here.
Wow, that's,
Yes, in the 1800s.
tell us about the Alamo.
Yes, no, we are post the Alamo, yes. And so when they asked me to do, I said I can do any of my talks. RA and its mimickers. RA is a polyarticular joint disease, and so its mimickers have to be polyarticular, or you don't really think RA. And my differential for a geriatric population, as far as new onset disease, is very different than my differential for a 25-year-old. Okay, and so like in here, I have a big section on the spondyloarthropathies. I really don't expect or anticipate that's incredibly low on my differential for somebody with new arthritis, 60 and over. It's just, we don't just generally see it. I can always tell you exceptions of that. So, here, I'll just do I have to point it at something?
Let me see here.
You have to tell Joe next slide.
What?
Well, there it is.
Oh, different. It's like the fake advancer and the real
Aha,
advancer.
gotcha.
Yes, yeah, okay. So polyarticular joint disease. So this is, this is the very basic outline. And so you have, how do we classify them? Well, you have inflammatory, so RA is clearly inflammatory. And then you've got number of joints involved. You can divide them monoarticular, and the classic one we think of as monoarticular is gout, that's inflammatory. You have polyarticular, which the classic one we think of as inflammatory is polyarticular, the spondyloarthropathies, exceptions to that. And then polyarticular, our classic one is RA. And then we want to know, and that's usually how you classify for pediatric, the pediatric world of JIA, they actually have numbers. If you have 4 or less, it's classified as POSI. And distribution, is it symmetric or asymmetric? And RA is symmetric. I'm jumping to my peripheral or axial. So, is back a dominant component? I don't think RA. Do they have small joint involvement? I think RA. What distribution of small joints? Is it MCPs? Is it DIPs? Is it primarily large joint? So hip, knee, shoulders, kind of thing. I think differently. And then obviously, most of our RA is not self-limiting. Rogers would be self-limiting. Poor thing, if you come in late, we make you walk past everything. Chronic early. So that's just the format. So age, male versus female. RA is predominantly female, but we sure have a lot of male veteran patients with RA. We have, and whether they have other organ involvement. Skin is very helpful to us. Eye is very helpful to us. I make him follow me around the room. Okay, so I have some cases. I'm actually going to stand, sorry. Thank you, jump up so that I can see this. And I can't remember what cases I put in. So you have a 57-year-old rancher who presents with 4-month history, so new onset of something, progressive joint pain and swelling. And he has synovitis, and his synovitis, so it's polyarticular, and he has small joint, and he has large joints involved. No nodules. And so what is your differential and what would you order? Well, this is really something that I think of as RA. It's RA, it's a little older than I usually think. He's a male, but it started in this range. I'm not going to think particularly, I don't think of, okay, I was very sexist. I'm assuming a rancher is a male, but I don't really think of lupus in 57, although I've seen it onset in an elderly patient. And so I'm going to work him up for RA first. You playing the statistics, you go to Vegas, you bet RA for this. 76-year-old presents with joint pain involving multiple joints for several years, bony enlargement of the tenderness of the PIPs, DIP. So this is hand, small joints, thumb, CMC. So he's got some shoulder problems, got some effusions of the knees, he has hallux valgus of his toes. What's your differential in this? So this is what y'all see all the time. This is somebody with polyarticular OA. Most likely, nothing I've given you suggests an inflammatory process. And one could say if it's so classic enough, do you need to order anything? I mean, this is, should you order rheumatoid factor? Well, this is somebody who has a high chance of having an incidentally picked up rheumatoid factor. Just because as we get older, rheumatoid factors or ANAs become more prevalent in our population, and they're distractors. And so, should you waste money? It depends on how comfortable you are with looking at that and saying, this is OA from either exam or what you have. So a 55-year-old woman with a 15-year history of psoriasis on topical therapy only. And now she also says, oh, by the way, I've had hand and foot pain for 5 years. And on exam, she actually has swelling and tenderness of PIPs, and a single diffusely swollen toe. And what's your differential on this? Well, from my standpoint, my first differential is psoriatic arthritis. But this can be confused with RA because of the distribution. But that BIP is particularly problematic. Does that bother anybody for RA when I say BIP involvement? RA generally spares the DIPs until really late. So DIPs as a dominant joint would be unusual with RA, but it's actually really common with psoriasis. And I can show you some variants of that. So that's somebody I think of as, so we have a 78-year-old widower with mild dementia, presents with swelling pain in his right wrist. That comes in because his wrist hurts. But on exam, he didn't bother to tell you, but he's got swelling of 2 PIPs, one MCP, a wrist, a bursitis of his elbow, contracture, so something's been going on longer than he knows. And he's got some shoulder problems, he's got an effusion in his knees, and he's got ankle swelling. And so now what do I think on this? Is this RA? I mean, he's got polyarticular, multiple joints. Okay. He's a little bit asymmetrical, which is a little bit bothersome to me, a little bit old for RA, not that I haven't seen it. And I actually have the answers to these at the end, but just to save us getting there, this guy actually had gout. We got it from his elbow, and he had tophi everywhere, and this had been, some of these were just there, and he'd been living with it so long, and so he actually presented with gout. And we occasionally see people coming in, and they get told they have RA, and we find out that they have polyarticular gout. There's this, and since I haven't looked at this, since I sent in the original slides, I don't remember where in this I talk about this, but there is a subset of people who present with gout as a polyarticular disease. More common in women. They don't have that preceding, I had one toe, then I had one ankle, and then I had a toe and an ankle, this kind of intermittent thing. And this guy was interesting because when I called to tell him he had gout, he goes, hey, they told me I had gout 15 years ago. And I'm like, oh, that would have been really helpful up front. I had a patient, 74-year-old female. She came in with a past history of RA. That was in her chart, everywhere in her chart. And it had been, quote, in remission for many years. Now, I don't like that. I don't know what happened then, but RA doesn't typically go in remission. I mean, and she was on no therapy for it. But she clearly related these episodes 15 years before or sometime in the past of having acute joint swelling. Doesn't remember what she took, but got treated. It was a problem for a while, and then she got off medicines and didn't come back. And she came in with this migratory swelling and pain in her tendons of her hands and her wrists. So she'd have like one finger, and then she'd have like it swollen over the back of her hand. She had no nodules on exam. She actually went to surgery, and this is now, since I led into this, she actually ended up having gout. And my suspicion was her diagnosis of RA years ago was not RA at all, was probably her early manifestations of gout. Got treated with prednisone and got better. And so and then for whatever reason became quiescent over many years. So although I say RA, in a geriatric population, obviously OA is going to be more common than RA. And I probably should put RA before OA, but you all know these statistics. The classification, what I always remind the house staff is OA is a problem of cartilage loss, okay? It tells you that there's something wrong with the cartilage. Now that can be, that's not a normal process that the cartilage goes away, but anything that damages cartilage leads to OA. Does that make sense? Am I running in the face of something somebody knows otherwise? So we think of OA as so in some ways OA is a end stage of multiple inputs, okay? So if I am a pro football player, I tear my meniscus, I do tendon damage, somewhere along the line I've damaged my cartilage, I'm more likely to have in that knee versus another knee OA prematurely. My boss, when he has a lecture on RA, and he has a picture of Joe Namath, just essentially crippled with polyarticular OA from multiple injuries. If I have rheumatoid arthritis, I have an inflammatory destructive process, and it's going to damage cartilage just like it damages bone and tendons and synovium, and I can end up with what's the most common x-ray finding of the knee, and RA is actually OA of the knee. Okay? It may be a result of the prior inflammatory process, and the question always for us is this knee problem they're having because they still have active inflammation in that knee, or now has it just been so damaged? Kind of like, I use the analogy sometimes with patients of having termites. Even if you get rid of the termites, you still have the damage they left. Okay? The classic finding for board exams for internal medicine, when they ask you what's the most specific, is osteophyte formation or new bone formation. And so cartilage is a hydrophilic. I feel like somebody in here probably has talked about OA before, and I'm really, cold to Newcastle kind of here. But so if you have, and that is a shock absorber. So it's a squishy, and so it disperses forces that the bone would see otherwise. So if you take away that cartilage, and the bone sees unopposed forces, it's going to remodel trying to react to those forces. And so if I need to carry a bigger load, if I need to remodel, the way to do that is increase your surface area. The house staff never admit to anybody being a mechanics major, a science major in college. But so that's where you get osteophytes. So here you have a cross section. The blue is cartilage. Here you have these big areas. It just makes me happy to swing it at the screen. So you have big areas that are denuded. And here's your osteophytes that are trying to disperse over a wider area so that any individual part doesn't see that much force. Okay. And so in a finger, you see loss of joint space because the cartilage goes away. That's really, really fuzzy. And so risk factors, y'all know the risk factors. But it's anything that comes in. You have, if you hurt the joint, if your knees, obesity is clearly a risk factor for knee OA, which is interesting because it's not for hip OA. You don't want to choose. There's clearly genetics, particularly strong in female hands for OA. Distribution, the distribution, DIPs and PIPs. And I point DIP and PIP out because that's where one of my things that distinguishes it from RA. And the thumb CMC and the MCP of the thumb also. So, but the point when I'm comparing it to RA is going to be that I shouldn't see MCP disease, I shouldn't see wrist involvement, I shouldn't see elbow involvement. And we usually don't mention the shoulders because they're always confusing to us. Okay? So here's a hand, you see these all the time, and in comparison to the RA pictures, this has a nice wrist, this has a nice MCPs. They're bony, they can get cystic changes, so our house staff in medicine will confuse them with actually swelling the cyst kind of things. And so that's the distribution for OA. Now so pain, y'all know this. Tenderness crepitus is the bony enlargement deformity, non-inflammatory. I said I borrowed my talk for PolyArticular from the house staff, marginal osteophyte stress space. And the fluid should be non-inflammatory, right? So that's one of the ways that when I said the person with RA who has a bad knee, if I tap it and it's not inflammatory, then I'm going to assume that it's no longer active inflammation, that they now have just damage. You know, and saying that, oh, it's polyarticular, we clearly see people that have generalized OA, but, you know, they may have monoarticular, they may have just a few joints. But we have these odd subsets, and this is actually what I added for y'all, was these subsets of disease. Secondary OA I've talked about, you have somebody who has some other process, but are y'all familiar with erosive OA or inflammatory OA? She nodded yes. No, I hear no. And DISH, do y'all know DISH? That's a no. Okay. Those are going to be issues that come up in an older population. And these, okay, either that is really out of focus, and I have no idea how to make that focus. So erosive OA, since we have a mix of people who know erosive OA, we get sent this because the radiologist reads it as an erosion. And yes, it is an erosion. This is really hard to study. There's not a lot of people who go in and do, that we have path on this, but this is a hand involvement. And it's DIPs and PIPs, so it's got the distribution of OA. And it has erosion, so they send them to us for RA, and we've had people that get rheumatoid factors, and they get worked up for RA. They should have sparing of their MCPs. They shouldn't have wrist involvement. And I said I never like RA for something that it primarily involves the DIPs. The erosions in erosive OA are they're different than the erosions I see with RA, and I'll show you a picture of the erosions in RA when I get there. These are central erosions. RA erosions are at the side of the joint, and I'll tell you why when I get there. But these are actually where the cartilage is central, okay? As opposed to RA, the erosions are where the synovium touches bone. This is not considered, it is sometimes classified as inflammatory. I've never gotten fluid from any of these joints. I can't say that I particularly tried tapping because I'm never going to get enough fluid from a PIP to send for analysis unless the thing is huge. But these get treated there's controversial literature about whether they respond to immunosuppressives, but most people don't think they do, and they get treated as a variant of OA. Okay? But this is something that, and they're in the population with OA, so this is the same 75-year-old woman, she's got DIP and PIP disease, the x-ray and this evaluation comes back as this erosive OA, or they'll say erosions, and sometimes they may or may not actually say degenerative arthritis in the report, and then that gets confusing for everybody and they send them to us. But the patient looks like OA, and variable degrees of pain. Okay, none of these x-rays are going to work, and I don't know why they're fuzzy.
Why don't we turn the lights down?
Okay, I think they're still going to be fuzzy.
Yeah.
Oh, did that
That's
really
much
help?
better.
Yeah, much
I was a radiologist.
Okay, there you go. Oh, now I'm real, okay, thanks. Now.
Oh, no worries. I did neuro.
Okay, yes, but if you were a radiologist. So this is a great looking wrist. Those are actually probably pretty good MCPs. Thank God it's really kind of fuzzy. But you still have this, and the classic description is Gull-wing, G-U-L-L wing. You know, like you used to draw a seagull when you were a kid, flying over the little four-stick boat in the little sea. And that's what they look like. They do this kind of, then that's the classic finding. And I would say we get one probably every, a few times a year, somebody sends us somebody like this with a question what they are. And this was the thing that was put on the slide, because it was like, all right, I was like, does somebody know they put in erosive OA? Because I was looking, and for some reason it's hard for me to tell. So here's the classic exam and the x-rays. But it's, okay. So DISH is another variant of OA. And in here, our differential comes into the spondyloarthropathies. So this is an elderly guy who has immobility of his back. Okay, now for me, somebody walking along who can't turn their torso, I think ankylosing spondylitis are spondyloarthropathies. DISH, diffuse idiopathic skeletal hyperostosis. Ooh, did I not put this on any of our titles? It was on that last thing. So, is fibrosis, a calcification of the anterior longitudinal ligament. Okay, and so, you know, if you know, and I've had radiologists You know, they'll read, x-rays done in the back 1 year, we'll read it as dish, next year they'll read it as ankylosing spondylitis. It can be very hard to distinguish. Hopefully these are not. The osteophytes with this tend to look more like degenerative in that they come outwards and swing in again, okay? So you essentially kiss these together, okay? So people think, oh, that's the bamboo spine, but bamboo spine is a much finer calcification. And it has to be 5 levels contiguous for it to be officially to be called dish. But the patient presents with a lot of immobility. This isn't somebody who has history of back problems since they were age 25 though, okay? I had a huge argument one time with a primary care who said, but this person can't turn their torso, they're, you know, starts reciting to me the exam for ankylosing spondylitis. I'm like, but ma'am, their x-ray is degenerative. And so, oh, you can't see that either. Okay. So here, more obvious, you know, that this is kind of almost unilateral, and you can see the osteophytes coming out, but not quite yet kissing along the top, okay? And you can understand that once you have this calcification, you're going to have decreased mobility of the back. You know, it's not specific for ankylosing spondylitis. But I will say that, you know, so I could say, okay, so somebody's coming in at the age of 70 who's never had a prior ankylosing spondylitis, what are the chances? I've seen it. I have seen people who missed ever getting a diagnosis of ankylosing spondylitis and get a chest x-ray taken at age 70 when they get admitted to the hospital, and the radiologist goes, oh, by the way, they have ankylosing spondylitis. And we get our first consult for that patient at age 70. And here again, they kind of bow outwards, they start to form outwards, and then they come along and connect back up. They also do tendon calcifications, you can see along the tendon there, in diffuse idiopathic skeletal hyperostosis. So hyperostosis was the next. Okay, I don't remember what this is pointing at. Oh, I don't know the arrow, but they can do heel spurs, which so can ankylosing spondylitis. So this is where we get into a problem with our spondyloarthropathies, with this kind of back involvement. And you know, some of it's the talent of the radiologist, you know, how much are they aware of the differences and the fine distinctions. Here we actually have musculoskeletal radiology, at least at the university. So all the MRIs that are done on bone or backs are read over at the university by the musculoskeletal radiologist. That's not true for the plain films here. Here's calcification along this tendon here. Those may or may not be symptomatic. Okay. Question?
Where was the tendon? Sorry.
Oh, yeah.
Okay.
Sorry, this works like for 1 second and, oh yeah, okay. It's not very bright. Okay. So there are a lot of things that OA, as I said before, so inflammatory diseases can give you OA as the end product. And there are some diseases that are classically associated with OA. House staff learn CPPD, but they learn it as pseudo-gout, okay? So chondrocalcinosis is calcification of the cartilage. It's not more specific than that. It usually is calcium pyrophosphate, but not always, okay? You can also have calcifications from basic calcium crystals. If you think about something, so if I calcify my cartilage, and I say that cartilage intrinsically is a shock absorber, and I start calcifying it, I'm not going to think it's going to work very well. If your cartilage doesn't work, you get OA. Okay? So that doesn't particularly surprise me that the most common manifestation of chondrocalcinosis is actually OA, rather than pseudo-gout. Now, if it sheds off enough to create a secondary inflammatory response, then you get pseudo-gout. But in most cases, as you probably know, chondrocalcinosis is picked up incidentally. Hemochromatosis, iron deposition. You're depositing in your cartilage, just like you're depositing everybody else. Cartilage no longer works very well, and you get secondary OA. It's actually a more complicated process than that. Wilson's disease is copper. I've actually never seen Wilson's disease. Avascular necrosis. Not a cartilage problem, but it's a bone problem. You kill off the end of the bone. That causes remodeling. That causes abnormal forces, and you end up with a joint that the end stage of that is OA. Charcot joint, that's not inflammatory. That's a neuropathic process. Most often diabetes in our population. Classic description was with tabes with syphilis. And then I said all of our inflammatory diseases that actually do joint damage. Does that make sense? You know, so all of those OA is the endpoint. Now the interesting thing about some of these is that they might produce OA in atypical distributions. So here's chondrocal. Ooh, look, no, it's, you know, you should have, that should be black, okay? Cartilage is radiolucent. And this is way, can I convince you that there's a bunch of stuff in there that's not supposed to be in there? Here's the ulnar styloid. Here's the shoulder with it. It looks like a double line. So, like if I go back, we don't get OA in the wrist, but if I make enough damage to that wrist, I might end up with OA, even though that's not a typical joint for OA. Hydroxyapatite, which is our basic calcium pyrophosphate. Do y'all know Milwaukee shoulder? It's an acute, is described in Milwaukee. That it can be knee, most commonly described in the shoulder. I've actually never made that diagnosis, although I've suspected. Hydroxyapatite is a calcium crystal thing. It's not visible under plain microscope. It requires electron microscopy to identify. It can be stained with alizarin red on pathology. I one time walked down and said, do you know what happened? And nobody in the lab knew what alizarin red was, so I've given up. But so this is more a diagnosis, but it's a OA process. Can have huge effusions, but they're non-inflammatory. So again, it's not like a pseudo-gout question, and can have a fairly rapid OA progression. Hemochromatosis, so I'm getting iron deposition. It's not going to be specific to the joints that are common for OA. Okay, so now here's something that people do that is problematic, because they come back with abnormal MCPs. So MCP is a distribution I don't expect with OA, but is actually for room fellows, you show room fellows something with, and they get these things, and you can't see it here, called hook osteophytes, these things that come off like this, that are supposed to be classic. So they get OA, these people with secondary OA can get it in unusual joint distributions. Charcot, just this dramatically destructive process in which they're painful, but just not in proportion usually to what you see. And I'm sure y'all have seen neuropathic joints. These are in the toes. You can't see, but that's a very destructive toe picture down there. OA therapy, I don't know this is. Okay, so RA in contrast, now RA symmetric autoimmune, polyarticular. OA and all the OA processes, unless you have something like hemochromatosis, should not have secondary organ involvement of any kind. You know, it's 1% of our population. I say I had a high school class of 100 females, and I know of 2 of my classmates who have RA, of females. You know, generally we think of it as women in their childbearing years, but I've seen it onset in the 70s. I've seen it, we have plenty of men with it. There are some genetic predispositions. This is a synovitis in contrast to OA. So a synovitis of those joints, so the problem is the synovial lining, and it's inflamed, it produces all these destructive mediators, and you get cartilage and bone destruction, okay? Joints are swollen, they're painful, they're red, or some variant of that. They don't necessarily have all of them. The classic deformities, well, here you have the swelling, so PIP swelling. DIP is relatively spared. They can have DIP, but I've never seen it as the prominent involvement. These are the tendon abnormalities. This is boutonniere. Boutonniere, like pushing a button. And swan neck, I always think of it as like a little swan swimming. Ulnar deviation, subluxation. I mean, this is swollen. These, even over here, is abnormal. We've got a very wide wrist. That's where, I mean, look at all this muscle wasting here, but then I should be able to see all those tendons all through here, but that's full of synovial hypertrophy and abnormality. Rheumatoid factor positive, CCP is our new antibody. I don't know if you all are familiar with that one. Anticyclic, highly specific, but not as common as the rheumatoid factor. Inflammatory markers. and these marginal erosions. Now, as opposed to, so in erosive OA, the erosions are these gull-wing things here. These are here. This is over time in a patient. And that's because here, this is protected by cartilage, so it's going to go away last. But here, you've got synovium up against bone. And so that's why the erosions appear peripherally. It can be very destructive. I mean, I'm going to look at this. Rheumatoid factor, you really don't know. The only point here is that 3 to 5% of the normal population is going to have a positive rheumatoid factor. Usually not high titer, but, you know, and hepatitis C, it's rampant in hepatitis C. And we, ever periodically, will get somebody who's been told they have RA that has, because they have a rheumatoid factor and PolyArticular joint pain in a correct distribution. And what they end up having is hepatitis C, and it's a viral arthritis. Hepatitis C usually is arthralgias more than arthritis, but it has a distribution exactly like RA. And so it's one of our big differentials. Lupus, less common than hepatitis C, can give you the same distribution of joints, not destructive typically. Yeah, okay, so CCP, you know, it's 95 specific if I get it, but not everybody with RA has it. But it's one of the things that helps us distinguish somebody. I mean, we clearly have people who do have hepatitis C, active viral load, and have rheumatoid arthritis, and CCPs can sometimes help us with that. RA, unlike OA, is an aggressive, it can have an aggressive extra-articular disease. It is a systemic disease. And it's the geriatric population that has our biggest problems. Males with long-standing RA are our biggest population for vasculitis with RA. Okay? The eye disease can be anyone along the line, can be very destructive. Scleromalacia, I had a patient who actually ruptured their globe from involvement of their eye, was a elderly male. And sometimes those can actually kind of occur when the disease is burnt out. Interstitial lung disease can be a big problem, generally when the disease is active. Neurologic involvement. Felties can be any age. But vasculitis, where they get vasculitic leg ulcers, and often can be in combination with Felties, has about a 50% mortality rate. And all those patients have typically been very elderly that I've taken care of without. So they have a lot of associated comorbidities and a lot of toxicities from our medicines. Yeah, I'm not real thrilled to put them on 60 milligrams. A lot of things about medicines. The thing I would point out is our medicines, especially the biologic therapies, and I actually haven't updated this to add the newer ones, have a lot of risk for infections. And that's problematic. I think we have a consult now over at the university for somebody on one of our, on a biologic therapy who's got apparently a decubitus post-surgery with a wound vac, and can they give him his anti-TNF? No, no. Seronegative spondyloarthropathy, not something that comes in as a new diagnosis for you, except for the lady I did mention about psoriatic arthritis, because a lot of these are ones that occur in younger people. So by the time they're geriatrics, they know that they have inflammatory bowel. Reactive arthritis is not that common. Psoriatic arthritis, the ankylosing spondylitis, except for the cases where somebody gets an x-ray and has never had a preceding diagnosis. So I've told you where this comes up. So these slides are in there if you want to read them. And the points, there were points, I had this because there were points that I was supposed to think of when the slides pop up. I've already told you about distinguishing it from DISH. SI disease distinguishes it from DISH. DISH should not have abnormal SI joints. But DISH should have normal SI joints. Has normal SI joints. It's not an if. So here, oh, that was it. So I can show you the comparison. These are very fine calcifications. They don't swing out at all, because this is actually calcification caused the annular fibrosis of the nucleus pulposus, okay, rather than the longitudinal ligament. Okay. They get the squaring of the vertebrae, so they actually erode the tips, so they're not as curved anymore. And so it's a much finer calcification than DISH is. This is a much more flowing kind of thing than this kind of things that look like they started out and then come back around. So as I said, these are young adults. Now where you get into a lot is these are very limiting to activity. Once this spine fuses, I don't know if I can convince you that this person probably may have permanent contractures of their hip. When he sits, he has to sit like this because he can't bend. He has, if you look, walking along, he has to do this to be able to look. So he's fused in this very not particularly helpful position. And I mean, you can think of and if he turns, he's not turning, he's going to have to turn his whole torso. Driving is a particular problem for these guys because they need mirrors everywhere. AS has a lot of large joint problems with it. It in general does not affect small joints, but one joint it does like is the hips. So when you bend over from two things. You bend from flexion of your hips, like this, and then you bend from curving your spine. If you lose the ability to curve your back and bend your back, then all of your forward momentum is directly from your hips. If you then take that out by having inflammatory disease and damage and end up with a lot of bad OA, then you end up with a lot of inability, essentially if something falls on the floor, you're not getting it back, okay? Because if you don't have that ability. Okay, so they do have complications. They have pulmonary fibrosis, neurologic complications. I've never seen it, but they can get actually Cauda-Equina syndrome, which is essentially untreatable. They can get inflammatory eye disease. They can get the aortitis, inflammations of the aorta, which is interesting. It's a proximal. They can actually get aortic regurg. Our biggest therapy advent in this is anti-TNFs. Nothing before has ever made a real difference in their back. And we still aren't quite sure that it makes a long-term difference in back progressive disease, but it makes a lot of symptomatic difference. So psoriatic arthritis, the problem that I'll say. So psoriatic, all of the spondyloarthropathies has as one of their bases enthesopathy, okay? Which we don't have in RA. So when I'm distinguishing, so when I say somebody has a sausage digit or inflammation of the entire digit, not just the joints, I'm thinking of this inflammation of tendon insertion on bone. Okay. So the thing that the spondyloarthropathies get, ankylosing spondylitis, Reiter's, psoriatic arthritis, that do not see in RA is Achilles tendonitis, inflammation of tendon insertion on bone. Okay. So, and I didn't say actually, but RA gets neck involvement, but it doesn't do back. So if somebody comes in, they have back pain, and I'm working up for RA, gotta know the cause of their back pain. I mean, it may all be degenerative, but RA should not cause back problems other than neck. The problem with psoriatic arthritis is this, and this is because it can have any of these clinical manifestations. So one of the manifestations in psoriatic arthritis is an RA-like polyarticular multiple joints. Typically has more DIP involvement than we see in RA. There is a subset that has almost specifically DIP involvement with very little other joint involvement. You can have something that looks more like Reiter's with an oligo, one ankle, one knee, that ends up being confused for gout. And then you can have the spondyloarthropathy that looks like AS. Okay, so here's a joint. You can see, okay, this is, so, and it tends to be more asymmetrical. So here it's got all the psoriatic fractures, but psoriatic nail involvement. We've got a DIP, we have a PIP, but DIP, we don't have a PIP. And the weird thing is, we've got a normal nail and a normal finger. The odd part of this is we've got thumbs involved. This is this variant that primarily affects the DIPs and the hands, and feet too potentially, is that the fingers that don't have nail involvement tend to be spared joint involvement. Isn't that weird? That just is always weirded me out. But this is more asymmetrical. It's got this DIP without a PIP. The MCPs can be involved, but they look really good on this picture. So if you presented this picture to me, even if I didn't see the nails, if you presented it just the joints, I would still worry about psoriatic arthritis because it looks different to me than rheumatoid does, or this is the nail disease. And the erosions are different too. They get this thing, hopefully we prevent this, called pencil and cup, okay? And where it erodes into this kind of teetering end of the joint. Reactive arthritis, I'm not going to talk about. You're welcome to, I mean, but when you read about it, I don't think y'all probably see much inflammatory bowel, bad problems with inflammatory bowel in the geriatric population. But we sure get it from our house staff, see it in our medicine house staff. There are viral infections that can mimic. I already mentioned hepatitis C. Hepatitis C is so the viral arthritis is parvo. Y'all know parvo, B19. So it's little kids get it, slap cheek disease, Fift's disease. In kids, this is interesting. The virus in kids produces a rash. Okay. In adults, it produces arthritis. So invariably, this is a nursery worker who comes in with new arthritis, or a mother of a kid that does daycare on Sunday school, and they know that the kids had parvo. They said, oh, there was a run of parvo in the school. And it's a self-limiting, which is one of the reasons why RA requires, it has an RA distribution, polyarticular, small and large joint, but it's self-limiting and goes away over several weeks. So it will respond to steroids. So that's one of the reasons why RA requires that you have symptoms longer than so many weeks to rule out this kind of viral thing. Hepatitis C, I've already said, can occur with active viral load, more arthralgias than arthritis, but can mimic RA. Hepatitis B, I haven't seen an active hepatitis B new disease in years. I got vaccinated for hepatitis B. So the hepatitis B vaccine came out when I was a house staff member. But we were still having, in my fellowship, still having patients coming in with hepatitis B. And in the hospital, we actually had I want to say a dialysis worker come in with new onset RA, but just got in very rapidly in a few days. And on lab, her AST and ALT were abnormal. Predated jaundice, and she goes on to have full-blown hepatitis B. But the arthritis in hepatitis B actually predates the jaundice, and then it actually gets better as their hepatitis B gets worse, and as their liver disease gets worse. There is an HIV-associated arthritis. Also, we think of it as viral. I don't think most of this falls into y'all's category. I would add that myositis can have, lupus and myositis can have, well, Sjogren's too, can have a polyarticular inflammatory arthritis that really looks exactly like RA, same distribution. Small hand joints, wrist, elbows, knees, ankles, polyarticular, symmetrical. They are not erosive. The myositis, we have a guy at the university now who's I can't remember who has just a kind of a fulminant myositis. It's an elderly guy. He doesn't have arthritis though. Then we come to our crystal diseases. And I've already mentioned that there is a subset of gout, and we would think, okay, these are monoarticular. So I mentioned CPPD, and it's mimicking of OA, okay? And pseudo-gout is usually monoarticular or polyarticular. Gout is usually monoarticular or oligoarticular, but if you miss that phase, or in a subset of people who don't have that prodromal kind of episodic attacks, then they're ending up presenting with polyarticular disease. And we've had cases of people being called RA. They get treated with steroids, so they get better, and then they get put on methotrexate, and they get put on hydroxychloroquine, and they get put on this and that, and I can't quite get them off their prednisone, and then somebody finally stabs a joint and goes, oh, you have gout, And they tend to be a little bit more, so by the time they're that, we're really talking chronic tophaceous. The tophi can be mistaken for nodules of RA, and I can tell you, I can't always tell the difference. I mean, it's easy once I know, oh, well, they have gout, so that's a tophi. Not because I can tell the difference. And so we periodically do have this issue. And the house staff don't always realize that gout eventually becomes polyarticular. So when they're seeing it, their little minds go, this is, something else. So obviously women get it later than men. Y'all know all of this. Here's podagra. Here's the little crystals. They're so pretty, spiky little things. But I would also remind you, not that it's pertinent to this talk, because it doesn't particularly look like, where it differs is it can do a tenosynovitis, which we don't usually see. So they will come in with a whole hand swollen. They just called me about somebody from the medicine clinic, and I was really, really pissed. This person the house staff member says, well, it hurt in their thumb, but they didn't hurt over their other joints. But then she tells me his whole hand is swollen, and he can't do this because it hurts too bad. I'm like, so his tendons are inflamed, go put them on steroids. Don't, and then you can get dragging tophi that have sheets of crystals. Bursitis full of tophi. They get these big, this is essentially a tophus. And it is an erosion, it's an erosive process. Gout attacks, I don't know if it's really. This isn't really a gout talk, but acute attacks, essentially by the time they're polyarticular, they're chronically having some kind of an attack. Okay. Something's swollen all the time, multiple things are swollen all the time, variably painful. And so treating the attack, the inflammation, I've got 3 choices. I've got non-steroidals, I have colchicine, and I have steroids, period. That treats the inflammation. Whole different ballgame is treating the hyperuricemia. That's the long-term treatment. This is the analogous to if I have diabetes and I have neuropathy from the diabetes, my insulin doesn't treat the neuropathy and my Neurontin doesn't treat the diabetes, okay? So long-term is their hyperuricemia, and the two have to be considered differently. Yeah. But here I'm going to give you hand. This is a big tophus sitting there, but this is chronically inflamed. It's a foreign body. You can actually see the tophaceous material. And, at some point, this woman, is this a tophi or is this just a cyst from her OA? I don't know, just looking at it. Here's another hand, okay, well, here I've got, this is a big swollen, I've got a big fat wrist, fingers don't look that bad, but, I could say, I could put this up and said, this is RA, and you probably would have believed me. You would have gone, oh, that's it. Or you can have, by this time, this is pretty obvious that this is an OA, or RA. This is, all I have to do is scrape some of this onto a slide and take it down and I'll have sheets of crystals, right? Okay? This is huge. These are huge.
Does this have to be untreated to advance to this, or can it be treated and still advance to look like that?
Only if it was inadequately treated.
Oh, okay.
So what's the goal of treatment? What number do we look for?
Less than 7.
What? Blah, 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 blah.
Is it less than 7? Your acid level is less than 7?
6, less than 6. You deposit at 6.8. You reabsorb into your serum. Any level over 6.8 deposits into tissue. Under 6.8, reabsorb. So unless you keep the levels, so we go for, and that's kind of a more or less number. And since everybody's levels vary so much every day, you need to push it below 6. And if you want to treat tophi like that, you probably need to get it down even lower.
So we shouldn't be seeing polyarticular gout at this point, like in society at this point, right? Because people should be treated well.
Yes, that is so true. That's why we had to add a gout clinic to our rheumatology, because we're getting so much crappy consults. We had a guy that used to be followed by us that had a controlled uric acid, goes back to his PCP. He was on 500 valopurinol. He was on a 300 and 2 100s. First the 300 gets dropped, then one of the 100s gets dropped, then he's on a 100 thing. And they watch him develop tophi that look like that over the last 5 years. The guy's suicidal. And he sits he gets admitted to the hospital for his bad breathing and all his medical thing, and he sits there squeezing tophus material out of these. And we get consulted finally from ortho because he has a non-healing ulcer that's bleeding all the time. Really? Really? And okay, so he has mild renal insufficiency, and people were I think either just didn't realize he was on more than one medicine, they just repeated what the last person had done, somebody missed it, or they were saying he's got renal insufficiency and these are too high a doses. But nobody was checking uric acids, and that's the other thing. You don't put people on blood pressure medicine and not check their blood pressure. So why put people on allopurinol or something for the uric acid and then never check a uric acid? I mean, but there seems to be a disconnect in what we understand. People will pay attention to it when it's acute, and they're not paying attention to it anyway. So, sorry. You hit that button. I just start spewing. Oh, look, there you go. We only have really 3 things.
Do you like Uloric?
You know, I think the numbers, this renal limitation to dosing on allopurinol is completely bogus, and there's data about that.
Could you say that again?
The renal dosing for allopurinol is, well, I'm being overstated, is completely bogus. There is no, I don't think, we have data that says you don't have to limit the dose just because somebody has renal insufficiency. So most of the time I see allopurinol, people are on Uloric because they were never adequately treated with allopurinol. And this magic about, oh, well, they're on 100 or they're on 300 and, you know, well, they're on allopurinol, but they're not getting any better. Well, you know, it's because you dose for where you want your number.
What's the highest allopurinol dose you've ever used?
I know I've used 700, but most people are okay up to 800.
Like over a day? Or, okay.
We
Is
have
it
a
just
bunch of
once a
people
day?
on 600.
Every day?
What?
Once a day or?
Yeah,
Oh.
once a day. Okay. You know, we're really running out of time, but polymyalgia rheumatica can be, you know, obviously y'all see that a lot. I'm sure y'all do talks on that. It's a large joint arthritis. It's not a small joint. So usually I don't have a problem with distinguishing it from RA, but I have had a lady who was in her 50s who came in. She had shoulder, pelvic. She was in her 50s, which is a little young for PMR, but she had a high SED rate. They gave her steroids. She responded, so they called her PMR for 2 years and couldn't get her off of steroids until she started developing arthritis in her little hands. It became pretty obvious at that point that she had rheumatoid arthritis. But she got called PMR for several years. You know, our time is up. This was me doing those patients again and telling you what they had. All right. Oh, I've got to go. Y'all got to go. And I'm change here. You go find my students. Yes, okay.
The cervical disability and rheumatoid arthritis, I usually interviews.
Oh, yes, and they have very long stages. X-rays are usually. So the chances are going to be. Oh, yeah, they have.